Hello, welcome, good afternoon, good morning, good evening to all our speakers, chairs, and wonderful audiences in different parts of the world. Welcome to this 13th episode of the ACNS Peripheral Now Diploma that was started last year. So today we have three wonderful speakers, Professor Jörg Bahm, Professor Mariano Socolovsky, and Prof. Libor Mencl. So we have three chairs as well, Prof. Amit Thapa, Prof. Shimon Roshkind, and Prof. Chandan Mohanty. And before we start, I would like to give this mic to Prof. Yoko Kato to say a few opening remarks.
Nothing to say, but today's topic is very, very difficult, but I think very interesting this evening. So we are very much looking forward to your talk. Thank you very much.
Thank you. So I'll hand this podium over to Prof. Thapa. Will you take over, please?
Yeah, thank you. Thank you for having me and the whole team here. In fact, it's a wonderful experience at the ACNS Peripheral Nerve Surgery Board. Every one of you would be aware that this is a diploma course in peripheral nerve surgery where we are talking about various issues from A to Z. And we have very esteemed panel of the speakers today. And it is a very exciting thing that we are talking about neonatal brachial plexus injury. And as you must have realized that we're no longer using the term obstetric palsy, which used to be there much more like prevalently used in previous days. Nowadays, we're talking of neonatal brachial plexus palsies. And this has a lot of connotations, which our speakers would be highlighting in their talk. So without a further ado, I would like to invite the first speaker of the day, Professor Libor from Czech Republic, and he is going to talk on a very important issue on the neonatal brachial plexus palsies. Professor Libor.
Okay, hello again. I'll just check my presentation. I would like to start. So thank you again for the invitation. I would like to start the first part of this topic, neonatal brachial plexus palsies. It is one of the most serious complications during delivery. The condition is not new. Smelly described it in 1764. And my aim tonight is how neonatal plexus palsy is recognized, assessed, and how we can decide who needs an operation. The reconstruction itself comes from the speakers after me. I would like to start with a brief introduction of brachial plexus anatomy. The plexus is built from the ventral rami of C5 to T1. The dorsal rami do not join it, they stay segmental. It may take a contribution from C4 above, we call it then prefixed, or from T2 below, then we call it postfixed. There are several structures which can protect the root from traction. There are sleeves, fibrous attachments between epineurum and the transfer processes. These anchors are weak or absent at C8 and T1, which is the classic explanation for why the lower roots avulse. One caution, this anchoring model comes from Sunderland in 1974. It is plausible, it is taught everywhere, but it has never been directly validated for burst palsy. Modern cadaveric traction work shows it's largely the direction of the force. Perpendicular pull produced preganglionic avulsion type injuries far more often than an oblique one. So it may be less about which root is weak and more about which way the head was pulled. We can see it on this picture. It's a very interesting article. Most often, the injury comes from excessive lateral traction on the head and neck, while the root shoulder remains strapped behind the mother's pubic bone, a condition known as a shoulder dystocia, but it has been also described after caesarean section as well. Here on this slide, we can see the gonic modeling, which show the body's own propulsive forces in labor, which are 4 to 9 times greater than anything in that can clinically applies. Once you add the caesarean and the intrauterine cases, The conclusion follows. A plexus can happen without any excessive traction at delivery. Its presence alone does not prove the delivery was mishandled, which is quite important message and can have a medical legal dimension. Then shortly about epidemiology, pooled incidence is about approximately 1.7 per thousand live births. The correction here is the trend. We were taught it was stable. In high income setting, it has fallen, nearly halved in the United States over 15 years. We can see also some data from Asia, like from Turkey and from India, which are quite similar. Some generally recognized risk factors. You can see it on the left. Two things we should take away. First, about half of cases have no identifiable risk factor. Second, even in the very highest risk group, diabetes plus macrosomia plus instrumental delivery, the actual injury rate is quite low, about 8%, which means prophylactic cesarean section wouldn't be necessary in a 92%. I would like to add some odds ratios. We can see here in this table from two studies. One is in a single center from Vaxury, and the second one is meta-analysis from high-income countries. What is the resulting nerve injury? We can divide it into four well-known grades. Neuropraxia and axonotmesis recovers. Neurotmesis leaves a permanent deficit. Root avulsion separates the root from the cord, and it is not graftable. The clinical point at the last line, usually the real plexus injury is mixed. It can be part ruptured, part neuroma at the next, and avulsion at the third in the same child. And how about the clinical picture? The most common distribution of the lesion is it possesses about 3/4 and more is the upper plexus injury. We call it ERPS pattern, and then followed by 15 to 20%, which are complete injury. Isolated lower plexus, called Klumpke injury, is very rare, and its existence as an isolated birth lesion is widely debated. About classification, we have this NARACAS classification, which survives because it is also prognostic, not merely descriptive. Group 1, you will rarely operate. Group 4, you will almost always operate. And early, the entire real argument, the reason timing is controversial, and lives in group 2 and 3. Now about the diagnostic, there are 3 pillars of assessment: examination, electrophysiology, and imaging. But what is very important is on the bottom line that the early referral is decisive for a good result and correct indication. We would recommend to refer to specialist assessment, ideally at 1 month of age. We use this active movement scale, which fits our use most. The reason is that the child is not cooperating like adults, and standard strength scales are unsuitable. It was first described by Curtis, 8 grades. 0 to 7 across 15 upper limbs movements. It's very easy to, not easy, but very well examination with the gravity as a reference. Then I would like to notice the Horner syndrome. which means a loss of sympathetic supply. It is very suspicious for C8 to T1 avulsion, and we were taught it is the strongest bedside predictor of poor outcome. But there are some studies like Yoshida and Kawabata who have some different opinion. So of course, Horner marks a very severe injury, but it's not an independent prognostic information. Now about electrophysiology, the role of EMG or electrophysiology is quite uncertain. Unlike in adults in trauma, the needle EMG very usually overestimates recovery, so we can find motor units potentials in a muscle that clinically does not move. And optimistic 3 months EMG has denied more children time with surgery than any other single factor. If you use it at all, an early study around 1 month is more informative than the traditional 3 months. About imaging, which is very important for diagnosis of root avulsions. MRI has quite effectively replaced CT myelography. In infants, there is no radiation, no lumbar puncture, no intrathecal contrast, and we also make a diagnostic of pre and also postganglionic curves of roots in one exam. I would like to mention the CT myelography as well because still possess the best individual rootlet resolution. So now it's reserved for some special cases. Very important message is that most children recover on their own, and it's about 2/3 of children, while remaining 20 to 30% of the nerves do not recover, and we would like to heal them and do the surgery, reconstructive surgery. And I would like to present our study in which we would like to identify the children who are unable to spontaneously recover. We have discovered about 227 patients in group 1. We give the patients with good spontaneous recovery. It is about 77%. About 22% of remaining had severe motor deficit and underwent surgery. Here are some factors which we try to analyze. Here's on the maternal and peripartum side. You can see diabetes, preeclampsia, instrumental delivery, forceps or vacuum extractor, and Apgar in first and second minute. And there is not a big difference. So we try to add some neonatal factors as you can see. There was quite big difference in Horner syndrome and humerus fracture. So we thought this will help us for identifying this group. You can see there is 1.7% in group of spontaneously recovered in Horner syndrome, and 15% in group with surgery. Unfortunately, we made or we add another observed parameter, initial movement at the first visit. It was a sum of MS points of the upper limb. You can see this the results, the resulting points. And then we performed the statistical analysis, logistic regression. First step was univariate, which were some promising result in terms of Horner syndrome. But after multivariate linear regression, this factor collapsed, and also only the movement in the initial state found to be significant. Here we can see the predictive power of our model of active movement scale in a first visit, which possessed about 0.8 and with in a 95% confidential interval. And we found this factor is the main and only factor predicting failure of spontaneous reinnervation. So at the end, what about timing, when to operate? Based on our experience, we recommend the total palsy with impaired hand function, early expiration, I mean about 3 months of age, and upper palsy without useful elbow flexion, about 6 months. We recommend surgery. Timing is still in wide discussions. There were several studies. I would like to mention TOBI 2020, and probably Mario will talk more about his indication or timing. Summary, and what is important, recognize early and means decide early. I would like to mention 5 points, which can be take-home message. Incidence is declining, it's not stable as we were told. About 50% of cases carry no risk, and at present is no proof of palsy. And second, 20 to 30% retain a severe residual motor deficit. Horner mark severity, not prognosis. EMG overestimates recovery. Serial clinical exam is primer. Conduction across neuroma does not mean recovery in infants, unlike in adults. And initial AMS, I mean initial movement of arm, predicts failure of reinnervation in our study with area under curves 8.88 and rate limiting step. Thank you for your attention.
Thank you, Professor Libor, for a wonderful talk. In fact, you have summarized beautifully the whole thing. Let me invite my co-chair, Professor Chandan Mohanty, to invite the second speaker for the day. We will take up questions at the end of all the presentations.
So, excellent presentation. So, I'd like to invite our next speaker, Professor Mariano Socolovsky, for talking on repair strategies in neonatal brachial plexus.
Hello?
Yep.
Can you hear me?
Yes.
Okay. I'll try to share my screen now. Is it okay?
Yes.
Okay.
Perfect.
Well, okay, I will turn off the sound of my computer, so in order to avoid bothering with the video sounds. Thank you, Yoko and Deborah, for inviting me for this to this webinar. Also, thanks Professor Raja, and thanks the chairs for this kind moderation and invitation. I will speak about repair strategies, and my life is much easier because Libor nicely summarized some basic things that we should speak about. So let's start with a conflict of interest disclosure. I'm a surgeon, so as such, I might be biased regarding surgical indication. Do not ask your hairdresser if you need a haircut. Of course, he will say yes whatever happens. So again, I'll try to be objective, but I might be biased. Second, another conflict of interest, which is if you are looking for a consensus, that will not happen. Will not happen here and will not happen in the next years wherever you go, because as this article nicely show, this is a work done by Alan Belsberg, by John Hopkins. He asked very experienced peripheral neurosurgeons about what do they do in OBPP, among others, and the results show that experienced peripheral neurosurgeons disagree in important ways. This article was published in 2004 and was repeated nearly 20 years after. And as you can see, the controversy still remains. So there is no consensus about the management of this pathology. But I'd like to summarize my talk in 3 questions, just 3. The first one, very important question is, should babies be treated as small adults? The short answer to this question would be absolutely no. There is no way we should think about babies like small adults, because we cannot apply our knowledge on adult brachial plexus surgery to babies. Why? Because of many things. First, a motorcycle accident, the typical issue that happens in a brachial plexus injury in an adult, gives a lot of kinetic energy in very few seconds. So it basically destroys the plexus by stretching it. And there is a lot of avulsions. By contrast, in neonatal brachial plexus injuries, there is less kinetic energy, which is logical, because the forces are much slower and are much lower. So in that way, there is a stretching, but not a rupture. This type of injury is very important. This physiopathology is very important to understand all our treatment, because basically we find a lot of neuromas in continuity, which is some fascicles rupture, they reinnervate, maybe with some anarchy, and that's why the typical injury is this one, the neuroma in continuity. The other thing we should consider is that in adults, we all know that the speed of growing of an axon is 1 millimeter per day, but in a baby is up to 3. Besides, the distances are shorter. If you think about the distance in between the brachial plexus and the hand, for instance, in a baby, it's nothing compared the distance in a brachial plexus injury in an adult to the hand, which is about 1 meter. So it is a reason why we cannot expect so logically to find hand reinnervation in an adult, but this is a fact in a baby. So being this the typical injury, the neuroma in continuity, as I said, the logical approach would be, of course, there are some issues, but the logical approach would be to cut and to put grafts and reinnervate the targets, the muscles. So this is the classical and still ongoing typical approach. Of course, there are nerve transfers and they are good and we use them a lot, but keep in mind this, because if you do only nerve transfers like many people does in adults, that will not work in babies, and it's not logical. Besides, neurolysis in this scenario is not useful, and this was nicely demonstrated by Howard Clark many years ago in this elegant study, where he's shown that being this a stretching injury and a neuroma in continuity, you cannot expect a lot from a neurolysis. So once you decide to go into a brachial plexus injury and operate on it, the logical thing would be even to cut and reconstruct with graft or to do a nerve transfer, but not a neurolysis. So having addressed the first important question, the second one would be how to operate this. We can separate this on upper and complete brachial plexus injury. Just to have an idea, it's not logical to give a 15-minute talk and to develop the whole strategy in such a complex issue as is neonatal brachial plexus injury. But in the upper type, as always, the targets would be elbow flexion and shoulder abduction and stabilization. So shoulder elbow flexion is addressed, as I said before, because of the physiopathology, if you have one or two routes available, routes to trunks with grafts. But also, you can associate nerve transfers, for instance, the overlap type. For shoulder, the same. We can expect, if we have roots, to reconstruct via graft, and we can associate the typical, for instance, spinal accessory to suprascapular nerve transfer. The results are very good. You can see in the right, the precise management of the shoulder and also the recovery of elbow flexion in a baby. So when you're using a root, you're having a lot of axons. The difficult thing is to know which root to use, which is also not so straightforward. But you can see here, in the left brachial plexus, the left upper limb, a nice recovery again of elbow flexion, shoulder abduction, and so on. And the same happens if you use some nerve transfers. So again, the strategies are there. We can train and we can use them appropriately. Again, more patients and more results. So the here, right side. The results are categorical and we can expect really good results, even much better than in adults because of the reasons that I mentioned before. In complete brachial plexus injuries, we have the hand and we should focus on the hand because it can be reinnervated. So hand is over there and we usually use our best roots to reinnervate the hand. And we can use other targets for shoulder and for elbow flexion. Of course, if we have only one root, we cannot expect to reinnervate everything so nicely. And we can use even contralateral C7. I think in babies, this technique still has a chance. So in one root, we can use it for shoulder and elbow and nerve transfers. And as I said before, contralateral C7, I think this is my personal view, we still have a role. So the typical result would be to have a adequate shoulder abduction, to have elbow flexion, and also to recover some hand function. It will not be, of course, piano player hand, but it will be adequate for hand grasping in many cases. And of course, remember about sensation, which is also very important in babies, in adults, not to mention, of course. Anyway, I want to refer to experience I had in Turkey visiting Ankara, and this very gentleman who is Professor Gürsel from Ankara, and he allowed me to visit his work. Basically, he has been doing contralateral C7 in babies for 20 years. So the results of this technique, we have less experience because we start to do this technique 3 years ago. So what I want to show is that hand can be reinnervated by the other side. And you can see here some hand reinnervation in these videos. So again, hand should be a target. Our experience, as I said, is much lower. This is not an obstetric, but just to show the knowledge. This is traumatic at a very young age, brachial plexus injury, complete flare, and there is some shoulder recovery by spinal to suprascapular, also elbow flexion, but you can see the hand. The hand was also reinnervated using contralateral C7, but still not solve the hand extension. And this is something that you have to prepare to when you use this this technique. And probably Jörg Bahm, my good friend, will speak about this topic in secondary surgeries, because you need secondary surgeries to update your results. And number 3, and don't worry, I'm finishing, I'll be short with this one, would be when. And Libor again mentioned this, and just to be, I completely agree with him, and just to be very synthetic, and I do agree in this statement. Good prognosis, do not require surgery, just physiotherapy in many babies, but not at all. And we shouldn't miss these few babies who really need surgery. As I said, this is true, but just in 70 to 80% of the cases. And I really recommend this article by the group from Leiden, Martin Malesi and his group, Pondag, etc., regarding the natural history, because we don't know much about the natural history for reinnervation. As I said, there is a less cinetic trauma and a good recovery of spontaneous reinnervation. So the ideal, which is not the decide, the ideal timing for surgery in MBPP would be in the upper type, study root avulsions with MRI, and decide if avulsed, you will not wait spontaneous recovery. You should go to surgery very early, 3 months, not earlier than that. If not avulsed, you can wait and see what's going on around 6 months or maybe 7, 8 months. You can decide whether to go into surgery and reconstruct or to wait. And incomplete, again, agreeing with Libor, I think we should go to an early surgical reanimation. So the take home, 3 questions, 3 personal, not consensus answer. Babies are small adults? No. Think on trauma. How? Use grafts for roots and also nerve transfers, but probably more roots used than adults. And when? 3 months incomplete, as a very short synthetic statement, and 6 months in upper type or partial types. So what I explain is this in the left. The reality is on the right. It's much more complex. Do not wait to understand this complex pathology in a straightforward line. It has to be analyzed carefully, each case after each case. Thank you. Thank you very much for your attention.
Thank you very much, Chandan. You can move ahead.
Yep. So I would like to invite our third speaker. We'll be taking the questions
Yeah,
at the end.
Prof. Shimon would chair this third session.
Sure.
Prof. Shimon?
Yeah, thank you. I have only one question to Mario. Mario, what is the main factor that determines your choice between nerve growth and nerve transfer?
If we have a good root, we prefer to use the root. First, because the brain is already already designed for managing the limbs with the roots and not with the nerve transfer, which implies a lot of reanimation of or reorganization of the brain. Besides, the number of axons is much higher. So how do you know if a root is working? First, and very easily, if there is a neuroma. If there is a neuroma, something is growing. Not growing good in a good way, but growing. So there is a connection with the brain. Second, after cutting the root, you can see and you can recognize. But of course, if you receive, for instance, a delayed case, if you receive a case after 9 or 12 months, and there is already, for instance, a reanimation of the shoulder, and you don't want to cut that root in order to lose your shoulder, then you can use a nerve transfer for elbow reanimation if it's not there at that time.
Okay, thank you, Mario. Okay, our
Thanks to you.
third speaker. Yeah, our third speaker is Dr. Jörg Bahm from Belgium, an internationally recognized expert in secondary brachial plexus surgery. He will discuss when secondary procedures should be considered and how they can improve function. Please, Dr. Bahm.
Thank you very much. Can you see my screen? Is it okay?
We're waiting for it to load.
Normally, I see it on my screen as I share
Yeah,
it.
now we can.
Yes, is it okay?
Yes.
So, hello, everybody. Thank you very much for having invited me and for the nice introduction. I'm probably the only not neurosurgeon in the teaching group, and I do not want to stress all the people who are listening because I will not so much talk about nerves now. Secondary procedures are often carried by plastic and orthopedic surgeons, and I am by training a plastic surgeon. And I chose a long time ago to do both. I do the primary and the secondary surgery. Now, to have a global view in 15 minutes, it is not that easy. And you should have a look at the pathophysiology. And always consider that you deal with a growing child. You have to consider first the characteristics of the initial nerve injury, either operated or not operated. You will always have to deal with the severity of that lesion and the extent. That is meaning a neuroma will always give weakness of muscles, sometimes co-contraction, and root avulsion will give initially fast muscle atrophy, and this has to be overcome later on. The extent of the nerve injury is also an important factor, and Mariano showed you nicely that it makes a world of difference between an upper and a total lesion if you go for the nerve reconstruction. Then, after initial nerve surgery, or even without, you have the process of nerve regeneration, a biological process, and of muscle renovation, which is happening, which will happen through 2 years and give you a particular functional status. And the way we look at it is either mostly looking on motion. So we will talk about active and passive range of motion. That's frequently in the publications, but we also look about strength and independence of movement. These are other important characteristics. More globally, the pediatricians, then they analyze limb function in a child. They will talk to you about the international classification of function. And there are specific items, and it is much more not about range of motion, but about daily use and life quality. So these are totally different factors surgeons normally do not handle. To make it a bit easy for you, I will go down from proximal, so shoulder level, to the hand. And first of all, you need to consider that for any secondary reconstruction, you will need free mobile joints. And that is particularly important at the shoulder level, because at the shoulder level, after obstetric palsy, you regularly have a disbalance between recovering or well-working medial rotator, which is subscapularis, and weak or not regenerating lateral rotators. And that will give you the situation, as you will see in this child, where the left shoulder gets blocked in neutral position and you cannot go beyond in passive range of motion. So before considering doing any muscle transfer, you have to consider that the joint is mobile and free, and you should avoid contractures either by physiotherapy, sometimes by surgery. In my slides, you always will see that there have been publications, and if you want to dive deeper in a given subject, you're of course free to read all of them. Why it is important for you nerve surgeons to know the basics of secondary surgery is because sometimes in primary setting of nerve surgery, you already might think to avoid secondary problems. So we started with free range of motion. At the shoulder level, the most frequent problem is this medial rotation position. So you have to identify it and to correct it. But it happens also at elbow level, where you might have a flexion contracture or radial head subluxation. This is rare, but it happens. And you have to deal it also considering the joint should be mobile. On the wrist level, you might develop ulnar dysplasia. And if you carefully look at the wrist and take X-rays in the growing children, you will find a lot of variations. And the X-ray on the slide shows you just one type where you have an hypoplasia of the ulnar head, and thus you will have an ulnarly deviated wrist. In fingers, it's mostly the clawing explained by hyperextended metacarpophalangeal joints, who is getting joint problem and who has to be overcome. The next point, probably for all of you, secondary surgery means doing some muscle transfers, but you have to consider that potential donors are frequently not healthy, but have been reinnervated as their motor nerve was affected by the initial trauma, has been probably repaired by surgery, but is not normal. And we also have to consider that we don't have by nature good donors for all movement types. And that makes it much important for your primary strategy. If you might know that you don't have a good secondary surgery available, that would put stress on you that your primary repair for a given function should be priority. For example, For the shoulder, abduction. There are not really good muscle transfers for a number of reasons, might be biomechanical. So in your primary setting, it is very important to consider nerve reconstruction of the shoulder in the baby, because your neurosurgical part will be the one and only, let's say. Another point is that with a severe injury, you might have neglect, and it's about sensation. And that is also an argument, for example, sometimes against nerve transfers, which are dealing with motor function, and privilege grafting, where you add sensitive components, which are very, very important, especially in a total lesion. Aim of secondary surgery is not the feasibility of a procedure. When I was a young surgeon, I trained in a unit where we said sometimes, oh, in this case, we could do a muscle transfer just because it is feasible, surgically speaking. And this should not be the aim. The aim should be the expected improvement of function and, of course, quality of life, and balance this with the risks the surgery may bear. For example, free muscle transfer, you always have microsurgical risk. You have to explain that to the family. Sometimes the parents won't accept it. So, next aim, as you are dealing with a growing joint, is to have good muscle balance around those joints. For the shoulder, it means you have to look at active lateral rotation, which immediately makes the suprascapular nerve a very important target. For the elbow, you need to have elbow flexion, but also some triceps to avoid contractures. So you will look for sufficient triceps function. And in the wrist, you want to beware the flexion contracture or ulnar deviation. Secondary surgery is always very individual and is age dependent. It makes a difference. You will not operate on a child who is 3 years old with muscle transfers. You will wait for the recovery of nerves, but it's normally preschool age. But if a patient shows up the first time with age 15, you will have to question to yourself, should I operate on him? He's finishing his growth spurt. He's nearly an adult. Also, should you consider the compliance for physiotherapy, because it's never only about surgery. So step by step, at the shoulder level, a release procedure might be necessary to free the joint, to get out of medial rotation contracture. And then you can add in the same surgery or secondarily muscle transfers, for example, for lateral rotation. Hofer transfer is well described, works well. I will show you some results we could achieve. For abduction, I sometimes use triple transfer, meaning part of trapezius, upper part of trapezius, teres major and latissimus to reconstruct both abduction and lateral rotation. At the elbow level, you might have to start to correct the flexion contracture by a release. And then you can secondarily do a biceps plasty by latissimus or free gracilis, or a triceps plasty. As frequently, primary surgery aims for recovery of elbow flexion. It's rare to do a secondary surgery for this purpose, because actually nerve surgery generally gives a good active elbow flexion. Procedures at the forearm include correction of supination deformity. So you will do tendon transfers of the distal biceps tendon or brachioradialis to activate pronation. And the wrist and hand, you will do much more classic tendon transfers known in hand surgery. First, to correct the drop wrist, and at the hand level to strengthen finger flexion or to correct clawing. What are the results generally you could achieve? A release procedure really, if done properly, at a good age, meaning around 2 years of age latest, will give you lateral rotation, passive range of motion of about 50 degrees. Hofer transfer, I will show you results in a table. And for the radial head reposition, you can get a midterm for about 3 to 5 years reposition, but you're always in danger of new subluxation. At the forearm level, correcting supination deformity, we published our results and obtained globally 20 degrees of active pronation. And the more classical tendon transfers for wrist extension, they give rather good results. At the hand level, it's much more complicated. And Mariano was citing contralateral transfers to add a maximum of input to get good basic hand function, because secondary surgery is not good. And the only aim could be to do a free functional gracilis transfer with a pre-positioned nerve, which is a huge procedure in a little child. And I did that really in rare occasion where the hand function completely was gone, and I obtained basic finger flexion, as you can see in this picture. Just to stress what we are talking about when it comes to the shoulder, lateral rotation is different in abduction of the arm, like shown here, or in adduction. For the joint, it is important to have a balance in adduction. So the release procedure will improve passive range of motion in this position to ensure a proper joint growth and avoid dysplasia. Now, these are unpublished results of a series of lat dorsi transfers we did, and this is like in every publication. I show you here, go quickly over the 109 patients. You see they were operated at 7 years of age. Some of them had a nerve transfer before. We had a long follow-up. Some of them had a reoperation, and that's the type of results we can get. And you would wonder, is this now good or not so good? And what I can point to you is that active lateral rotation with the abducted arm, which means putting your hand right on your occiput, improved a lot and remained rather stable over the years. That is the other point. Some of the results go down with growing age. So the discussion, of course, is about a lot of points, and I have to be short on that. Relearning in children generally is fast and good, but you should consider biomechanics and especially donor strength due to initial nerve trauma. Publishing retrospective cohort studies is the only we can achieve, but sometimes is not very sufficient. And of course, we were talking about motion and free joints and growing, and we did not so much talk so far about life quality. So I encourage every obstetric brachial plexus surgeon not only to be the neurosurgeon, but also to open his mind to have a more global so-called neuro-orthopedic view. So the take home is first, you need with secondary procedures improve the function and not do what is feasible. You need good mobile joints, and you can achieve a better lateral rotation in the shoulder. You can achieve an improved elbow flexion. You can position the forearm better. And of course, for example, correct a dropped wrist, which is very ugly functionally. In comparison to adults, here you see just a short comparison for adults. In adults, you do much more free muscle transfers. You have to counsel also prostheses, which in children are not a goal. And in the adult, you are doing, example, more bone procedures, as you will do osteotomies and sometimes arthrodesis, which you will not do in a growing child. I want you to look one more minute to my talk, as I may show you that all we have discussed so far in the 3 talks is about using techniques for traumatized nerves. But you could apply the same techniques for diseases where there is not a proven nerve trauma. Arthrogryposis is such a condition where we do not know exactly why a muscle is not working or why it is hypertrophic. And if you apply nerve transfers or muscle transfers in these children, you will get very rewarding results. I just want to show this one case. This child was supposed to have obstetric palsy, and that was the brachial plexus looking like. No lesion, hypoplastic roots. And it turned out when the child grew that it was an arthrogryposis. So some 10 years ago, I proposed this technique to say, in an arthrogryposis of upper limb with good hand function, I could do Oberlin transfer. These are pictures of Oberlin for a non-working biceps. The biceps was there, but it was not innervated. So I re-innervated the biceps. And in case if the biceps was not present, I did an early muscle transfer. So this brings you in a situation where you apply techniques from nerve trauma to illness, to some specific conditions. And you might understand for a child who never flexed the elbow, that is sometimes very rewarding. This ugly video shows you the first child I treated like this. The boy was 2 years old and he never had flexed his elbow before surgery. We did a nerve transfer and you will see that's the first time he achieved to flex his elbow. So this was very rewarding. And I will show you, just to conclude, a second child. And this particular child was born with a bilateral weakness of upper limbs. And you can see left side is much more severe than right side. And the wrist is ulnar deviated and the finger function is present but special. And it's not obstetric palsy. This child was born by cesarean, 2-kilo child, so was not obstetric. This is a particular form of arthrogryposis. And this is preoperative. And now you will have a look at the immediate post-op situation after an Oberlin transfer for elbow flexion. And you will have to wait some seconds to see that at one moment, this little boy will start to flex a little bit, helped by gravity. But it was the first time, you see here, he flexed the elbow and a flexor crease appeared. And this is the same boy 8 years later. He has grown, he has still muscle hypertrophy, but you see he gained an elbow flexion, an active elbow flexion. So now he's able to put the hand on the mouth, just because we were thinking very early about transferring healthy nerves into a muscle which was waiting for recovery. Thank you very much for your patience, and thank you for considering these options in the children you will treat.
Thank you, Dr. Bahm. Dr. Bahm, I have a question for you. When do you usually recommend second surgery, and how do you explain it to parents?
You mean globally, secondary surgery?
Globally, sir.
Yes. So I think shoulder issues should be done early. The shoulder joint needs a balance early, and this should be done before age of 2 years, because otherwise you run dysplasia. All the other secondary surgery there is no emergency. It may be dealt from 3 years on, and I try always to say, let's finish it before the child goes to school, because then it will have other considerations and there's no more so long time for physiotherapy. So that's the frame. But sometimes you get the patient very late. He shows up the first time, he's already 12. And then, of course, we explain to parents what are the possibilities, what are the normal functional outcome we can expect, and what are the risks. And we are more and more considering, of course, the risks of surgery. And it's a little bit for us surgeons, we will not, let's say, destroy our own indication. So I say to parents, I'm a surgeon, this is my job. I try to do it carefully, but it's sometimes harming and I have to deal with it. And you have to understand it. That's the way I go straightforward. I hope this is answering your question.
Yeah, thank you.
Thank you very much. I think now it's time I will launch the quiz and read out the questions. After that, we can continue our discussions. So
May I do a short comment?
yes, if you...
Oh, I'm sorry. No, you had the questions. I'm sorry.
Okay, so the quiz questions are here. I hope everybody can see this. We have 10 minutes and you can correct. There is only single correct answer. I'll read out one by one. Which of the following statements about neonatal brachial plexus palsy is correct? Incidence has remained stable over 1.7 live births. Presence of brachial plexus palsy is proof of mishandled. Approximately 50% cases occur with no identified risk factors, and elective cesarean section eliminates risk entirely. Second is regarding Horner syndrome in total neonatal brachial plexus palsy. Which statement is correct? There are 4 choices. The third question is, which is the most common distribution of the lesion in neonatal brachial plexus palsy? The fourth is secondary obstructive brachial plexus palsy. Second surgery mainly focuses on, and there are 4 choices. The fifth is most frequent OBP sequel is, there are 4 choices again. Active forearm pronation may be increased by 4 choices again. Then babies resembles adults regarding brachial plexus injuries in the following items. There are 4 choices. And last is select the correct answer. And the last question is regarding timing of surgery in neonatal brachial plexus. So we encourage everybody to please take on the quiz. There are 67 people here, or 58 attendees. Of course, there is no mark. This just, we want to evaluate how far we were able to convey our message and knowledge regarding brachial plexus palsy. So while the quiz is on, we will continue our discussions. I'll hand this podium over back to Prof. Thapa or Prof. Mariano. You were saying something?
No, I just want to stress, I don't know if the attendees are hearing because of the answers, but I want to stress the fact that if you're a neurosurgeon and you're doing obstetric brachial plexus injuries or neonatal, however you want to call it, you just have a small window and you need to work in strong cooperation with plastic surgeons like Jörg, with ortho surgeons, and with many other people. It's a multidisciplinary approach. Otherwise, you just see a just small window of what you have to see and treat. So in my vision, it's not possible to be just doing neurosurgery in these babies.
Right. Yes, Prof. Chandan?
Yeah, so I had one comment about, I think Professor Libor made a very nice presentation on, so he made a point about the fact that how EMG sometimes overestimates clinical recovery. So there is also a counterpoint where EMG sometimes you see good motor action potentials, but clinically you do not see good movements. So that can be because of 2 things. One can be a phenomena called as co-contractions, very, very typical. And second is to look for contractures. So I think Professor Jörg also alluded to that in the presentation. So when you are looking for shoulder abduction, you're seeing good contractions in the deltoid, but you don't see so much shoulder abductions because either the teres major or the subscapularis is under contraction. So that is also something that you need to be mindful of.
Yes. Prof. Shimon, would you like to share something?
I have a small comment regarding neurologists in brachial plexus. I completely agree with Mario. But from another side, I have a small group of the old birth-related brachial plexus injuries, incomplete all the related brachial plexus. And child underwent neurolysis during the surgery alone, intensive neurolysis, and child have a partial improvement after surgery. First of all, I don't found neuroma. I found scar tissue. I found diffuse area. But I talk only about old birth-related with incomplete brachial plexus injury. As for this reason, completely ignore neurolysis a little bit difficult to me.
Yeah, just to comment, neurolysis, it's an important part of the surgery in terms of exploring the brachial plexus and releasing some compressions or whatsoever. But I mean, as the message I want to deliver is, as the only technique, it might not be appropriate. And if you decide to enter into a baby with a brachial plexus injury, maybe just doing a neurolysis. This is a message mainly for young people. Shimon, you have a lot of experience in this topic. The message, I think, it's maybe just doing a neurolysis, which usually happens in the early or young surgeons, or in the first cases of surgeons. I think it's not appropriate.
Great. I would request the attendees to please continue. There are only 43% people who have participated so far. We encourage everyone to please try a hand at the quiz, and we have 5 more minutes. Yes, Chandan, you were saying?
Yeah, so I just had a comment. I think Professor Mariano showed some lovely videos. I don't know if the participants noted that or not, but all the kids with brachial plexus injuries, they usually have shortening of the limb on the affected side. The other side is normal, but one side is affected. So that also is something that you need to counsel the parents at the time of the first consultation itself, because unnecessarily, if some, it's very easy to forget, and then there can be a lot of misunderstandings because of that thing. Second thing is the other is in neonatal brachial plexus injuries. Another very odd phenomena is that of auto amputations, where the children just bite off their fingers, and sometimes you need to protect the hand. Whereas in adults, you see neuropathic pain, which is much more common. In children, you see this auto amputations, which are more common. So I just wanted to contrast based on the previous presentations on adult brachial plexus also for the participants.
Thank you. Thank you for that comment, Chandan. Yes, I think on one side, sensory recovery is of utmost importance to avoid what you mentioned. And second, it is a long lifetime experience, OBPP. It's not just doing a surgery a few months of age and that's it. Probably Jörg can comment on this, but usually, I mean, the shortening of the limb, the fact that in adolescence the young people do not do rehab, or they abandon rehab, they usually get worse results, and so it's a dynamic process.
For the finger biting, what I did several times, this happens in very severe desensitization of the hand. And what I did several times is using the intercostal brachialis, which is the second intercostal nerve. You can branch this on median nerve, the lateral part, at the level of upper arm. And of course, your result will be shown earliest, let's say 2 years later. But in the few cases I did, there was some improvement, but it's very difficult to objectivate it. So I had several demands about that, and that's what I proposed. And I mean, you need to resensitize by any means the finger palps. And yes, sometimes it is not feasible, but you might use, for example, intercostal nerves, which are not always part of reconstruction. I mean, the motor intercostals might be part, but the second is only sensory. And it fits the lateral median nerve. That's one thing. The other thing about the limb discrepancy, I answered writing to the question in the forum, so you can read my answer. But it is about, we don't know exactly what happens. probably it has to do with muscle strength and muscle distension. But it's obviously in the forearm and hand wrist level. Therefore, I always compare finger size in a total palsy after years. You immediately will know if it was a total palsy or not, just looking at compared finger size. But explaining what is the exact phenomenon which gives that, I can't. I guess it has to do with muscles. It has been documented. Julia Tertzis published a study where she did X-ray, compared X-rays, and you can objectivate what really happens on the bone side, but you cannot explain why it happens.
Thank you.
I would like to believe that those who have been operated on by all of you and all of us early by nerve surgery would have less limb discrepancy.
Well, thank you very much, Prof. We have the results of the quiz now. I hope you can see this results. Okay, so the question for the answer for the first question is approximately 50% of cases occur with no identifiable risk factors. Around majority got it right. The second answer regarding Honor syndrome in total type neonatal brachial plexus palsy, the correct statement is it is a marker of injury severity but has no independent prognostic value for spontaneous recovery. 61% got it right. And the third question, what is the most common distribution of lesion? The upper plexus, 84% got it right. The fourth question is secondary OBPP surgery mainly focuses on muscle tender and transfer, 71% got it right. The most frequent OBPP sequel is shoulder internal rotation position, and 66% people got it right. The active forearm pronation may be increased by Zancoli routing, only few got it correct, 18%. The seventh question is babies resemble adults regarding brachial plexus injuries in the following items. None of the above, 68% got it right. The correct answer for the eighth question is a combination of nerve root reconstruction and nerve transfer is usually recommended. And the right answer for the last question is regarding timing of surgery in neonatal brachial plexus injury. Select the correct answer, and the correct answer is at 3 months of age, surgery is recommended for partial palsies with root avulsion. So thank you very much. I hope you have a good learning session today. So if we can close this officially on behalf of the Education Committee of the ACNS and the Peripheral Nerve Diploma Committee and Professor Joko Kato, the President of ACNS, I would like to thank all the three speakers of today, Professor Jörg Bahm, Professor Mariano Socolovsky, and Prof. Libor Mencl, and the chairs, Prof. Shimon Rochka and Prof. Chandan Mohanty and Prof. Amit Thapa for the time and support for the ACNS webinars. All these webinars are archived and will be available on the official YouTube channel of the ACNS. So until we all meet next month again, it is bye-bye from all of us. Thank you very much for joining.
Thank you.
Thank you.
Thank you very
Bye-bye.
much.
Bye-bye.
Thank you, everybody.
See you. Bye.
Thank you.
Bye-bye.
Thank you.